loss of thin respiratory epithelium, irregular cell margins, coarse chromatin, pleomorphic cells. So how do I structure this? I can go, there's loss of the normal tissue architecture, there's migration of malignant cells into the stroma, irregular cell margins, so I can start cellularly and out. You can see pleomorphic cells with atypical increased nuclear to cytoplasm ratio, coarse chromatin, also observe irregular cell margins, invasion of cells, and a desmoplastic response. So there is the fibroblast proliferation. Thin respiratory epithelium, migration of malignant cells into the stroma, into pleural surfaces, regular cell margins, pleomorphic cells and nuclei. So microscopically, we can break it down into what's happening with the cells themselves. Otherwise, it's just and then we can link it to invasion as well. Invasion. They can be due to cells. We can have irregular cell margins, pleomorphic cells with coarse chromatin, and we also see invasion of cells into the pleura. There may be malignant cells in the stroma, and we may observe a generalized papilliform structures. Generalized. Let me see a papilliform structure. Papilliform structure. Right, and then aggregate of atypical cells, malignant is the final aspect of a adenocarcinoma. And the macroscopic changes, we're sampling the hilar nodes, looking at the tumor margins, looking for any scarring, infiltration. Okay, and in the original colorectal cancer specimens, what do we do? What's a pathophysiology? How would you report it? Synoptic report, microscopic, macroscopic changes. When we see ulcerated bowel, we may observe evidence of a exophytic lesion, potentially polyps, areas of necrosis and hemorrhage, nodules macroscopically. Microscopically, we may observe the cells themselves, maybe pleomorphic in nature, macronucleoli, increased mitotic rate, and then evidence of invasion as well. So in the notes, I can go back and write microscopic changes, invasion, and we may see necrosis as well, and macronucleoli. So desmoplastic stroma, so evidence of invasion, atypical glands. Why do we see a frozen section? What are you going to report? All done. Alright, let's go back and start doing more cases. So 17 left. I've done gastrointestinal. I need to go through the final farm case. So Gerald, cirrhosis, hepatitis, pharmacotherapy. So disulfiram. For highly motivated individuals, you do not use it for ischemic heart disease. It can cause nausea, vomiting, headache. How will I remember sulfiram with a metallic taste? Disulfiram. Disulfiram can also headache, metallic taste, nausea, vomiting, drowsiness, headache, and a metallic taste. And rarely we can get contraindications of ischemic heart disease, so it can cause palpitations, so contraindicated. Blocks mu-opioid receptors, it decreases dopamine-rich reward in the ventral tegmental system. Again, nausea, vomiting, but there can also be anxiety, dizziness. It's an opioid antagonist, so we can get anxiety, fatigue, and then a camprosate. It's not preferred in renal or hepatic impairment, and you can get rash, diarrhea. Now I remember, camprosate changes in libido. rash, or hepatic impairment. So your disulfiram is a acetaldehyde dehydrogenase inhibitor. It's contraindicated in events of psychosis and ischemic heart disease. It is preferred for patients who are highly motivated, and side effects include nausea, vomiting, drowsiness, headache, and it can also cause palpitations and a metallic taste. A camprosate is an NMDA receptor antagonist, and it works by decreasing excitatory brain function associated with the craving sensation of alcohol. It decreases withdrawal and cravings, and it can be given with naltrexone. Contraindications: renal or hepatic impairment. A camprosate, renal or hepatic impairment. It can cause diarrhea, rash, changes in libido. Alright, that's okay. Peptic ulcer disease. What pharmacology would I recommend? Virulence factors: it's gram-negative microaerophilic S-shaped flagella. Its virulence factors: urease degrades urea into ammonia, it has phospholipase, it has adhesins, and also a flagella. Flagella, adhesins, urease, and phospholipase. Pharmacology: the triple therapy used for peptic ulcer disease is that of a proton pump inhibitor, including, for example, osomeprazole. I like to also add on clarithromycin and amoxicillin, and if there is allergy to clarithromycin or amoxicillin, we may consider switching with metronidazole. And any other therapies I know. If there is resistance to clarithromycin, then we can use levofloxacin. So if there's resistance to clarithromycin, then we can consider levofloxacin instead. And that's a 10-day therapy instead of 7 days. And quadruple therapy includes, again, taking out your amoxicillin and your clarithromycin, and we swap for tetracycline, metronidazole, and we may consider osomeprazole, amoxicillin, rifabutin. Okay. In a patient with a H. pylori peptic ulcer, we may consider our initial triple therapy, which includes a proton pump inhibitor such as osomeprazole, clarithromycin, and also amoxicillin. If the patient has allergy to clarithromycin, we may consider using its resistance. It's resistance. Okay. The triple therapy for a peptic ulcer disease is the use of a proton pump inhibitor, including osomeprazole. We may also consider using clarithromycin and amoxicillin. If there is resistance to clarithromycin, we may consider using triple therapy using levofloxacin. So we can use your proton pump inhibitor, amoxicillin, and levofloxacin. This is a 10-day course rather than a 7-day course. We may also consider using quadruple therapy, which includes the use of a proton pump inhibitor such as osomeprazole, in addition to colloidal bismuth, which is believed to impair cell wall synthesis, and also the use of metronidazole and rifabutin. What are the mechanism of actions of two of these drugs? What is their mechanism of action? The mechanism of action of a proton pump inhibitor is it inhibits the production of... I need to go back and open the key slides up. It probably has images. Okay. Medicine, key, biomedicine, science, science, pharmacology, peptic ulcer disease, peptic ulcer, diabetes, glaucoma, hyperosmolar, renal infarction, peptic ulcer disease. So we've got our differentials. So the test to detect H. pylori, the gold standard is gastroscopy and biopsy. We can use the urease test on the biopsy, so it can place the tissue in an agar well containing urea, and the urease will cleave the urea to convert it into ammonia, alkalinizing the pH, and this can cause a resulting color change. And biopsy should be taken from both the antrum and the body of the stomach. And we can also do the urease breath test. How do you interpret? The biopsy was taken, and you can use a urease breath test. The patient drinks radio-labeled urea, which is broken down into ammonia, and the radio-labeled carbon dioxide is detected. And it has very high sensitivity and specificity, and active infection, and performed 4 weeks after treatment to ensure eradication. So we can do it 4 weeks after treatment. And the serology, you can look at serology and stool antigen as well, to H. pylori stool antigen. Okay, additional standards, normal chromic, with increased hematocrit, decreased hematocrit. I would also like to get coags to reverse any existing coagulopathy, identify any coagulopathy, reverse any anticoagulation. EUCs greater than 100 to 1 suggest a GI bleed, and gastrin levels. If there are multiple ulcers, we could suspect Zollinger-Ellison syndrome. It's insane. So the patient has a normocytic, normochromic anemia, which is consistent with anemia of chronic disease, and it can also be due to an acute phase of a bleed, and it will then progress to a hypochromic microcytic anemia due to the iron deficiency, and we may observe a mild thrombocytosis in response to the acute bleed. So H. pylori, biopsy is considered a benign chronic gastric ulcer. It was detected at the antrum. Why is eradication important? Because it has a spiral, it has mucolytic enzymes, it has adhesins, mucolytic enzymes, adhesins, and it can increase your risk of maltal mucosal associated lymphoid tissue, lymphoma, gastric adenocarcinomas, and use amoxicillin. We can swap the amoxicillin for metronidazole, and we can change this to levofloxacin, and quadruple therapy is the last line that we can use. What is their mechanism of action? Osomeprazole. It irreversibly forms disulfide bonds with the hydrogen potassium ATPase proton pump of parietal cells, which suppresses acid secretion. So proton pump mechanism of action. Hydrogen potassium ATPase pump, it irreversibly binds to inhibits the hydrogen potassium ATPase pump that exists in the luminal surface. So let's understand this here. Okay, so gastric glands, and you have parietal cells that produce acid, and proton pump inhibitors inhibit the gastrin activates the hydrogen potassium ATPase pump, and that can cause hydrogen and chlorine to exit, and we may get potassium exchange, and inhibits a pump which suppresses acid secretion, basal acid secretion. Parietal cells produce your acid. Okay, so it irreversibly binds to the hydrogen potassium ATPase pump, and it prevents the secretion of basal acid. And side effects could include potentially can cause. How does any of this make sense? It can cause GI upset, number one. It can cause headache and dizziness. How does that make sense? It can affect sleep disturbance. It can cause GI upset, sleep disturbance. This is just my memory game. So, a proton pump inhibitor can cause GI upset, sleep disturbances. It can also affect LFTs, and it can also cause an interstitial nephritis or a microscopic colitis, hypersensitivity. Penicillins, nausea, vomiting, diarrhea, Clostridium difficile, colitis, hypersensitivity reactions can cause photosensitivity, interstitial nephritis, and potentially hematological toxicity as well. Macrolides bind to the 50th ribosomal subunit. They prevent translation and protein synthesis. Macrolides can cause gut motility issues, potentially cause arrhythmias. They stimulate motilin, which increases peristalsis, and it's the most common cause. Macrolide, we can get arrhythmias, prolonged QT, cholestatic hepatitis, rashes, eosinophilia, and metronidazole. It's unknown, but it's believed that it produces free radicals that disrupts bacterial DNA synthesis, prevents replication, and this is going to also affect other rapidly dividing cells, can cause a leukopenia, CNS or peripheral nervous system toxicity, and much like your disulfur and metronidazole can also cause a metallic taste, and again it can also interact with disulfiram and cause a disulfiram effect and a Stevens-Johnson syndrome. So tetracyclines, doxycycline can chelate calcium in bone, tooth, enamel, cause discoloration, decrease bone growth, and allergies, nausea, vomiting, colloidal bismuth. Alright, let's see how good I am with that. Microscopic colitis, interstitial nephritis, sleep disturbances, GI disturbances, raised LFTs, and also hypersensitivity, bronchospasm. Okay, got it. Microscopic colitis, penicillin, interstitial nephritis, diarrhea, nausea, vomiting, motility issues, arrhythmias, leukopenia, CNS, PNS toxicity, metronidazole, doxycycline. Can also cause photosensitivity, nausea, vomiting. Okay, and this you can get ampicillin. Alright, let's go through. So what is the mechanism of action of all the agents that are associated with peptic ulcer disease? So we initially have our proton pump inhibitors such as osomeprazole, and these proton pump inhibitors act by affecting the parietal cells, and they irreversibly bind to and inhibit the hydrogen potassium ATPase pump, as a result reducing the amount of basal acid secretion into the stomach. The side effects of these agents include nausea, vomiting, sleep disturbance. There may also be bronchospasm. We may observe deranged liver enzymes, and also potentially interstitial nephritis or a microscopic colitis. And our other agent is your amoxicillin, which is a beta-lactam antibiotic, and this antibiotic builds up in the bacterial cell wall, binds to penicillin binding proteins, and prevents synthesis of the peptidoglycan cell wall. Side effects of beta-lactam antibiotics include, well, we can always observe resistance, but we also observe nausea, vomiting, gastritis, GI upset, and potentially renal effects, including interstitial nephritis caused by antibiotics, potentially a hypersensitivity reaction, and also observe potentially a small proportion of patients Clostridium difficile infection. And our next agent is our macrolides. Your macrolides bind to the 50th ribosomal subunit in cells, and they inhibit protein synthesis. As a result, we have bacteriostatic effects. And start again. So macrolides act by binding to the 50S ribosomal subunit, and they inhibit bacterial translation, and this is bacteriostatic. The primary side effects of your macrolide antibiotics includes gut motility issues, as they stimulate motilin, and this is one of the main causes of non-compliance. They may also cause arrhythmias and are associated with a prolonged QT interval. Also can cause cholestatic hepatitis, rashes, eosinophilia, and our next class of agents includes potentially tetracyclines. So tetracyclines such as doxycycline bind to the 30th ribosomal subunit, and similar to our macrolides, inhibit bacterial translation and production of polypeptides, which is bacteriostatic. Side effects is that tetracyclines can chelate calcium, and as a result they may cause enamel dysplasia, they may inhibit bone growth, and are not recommended for use in children. Tetracyclines may also be teratogenic, and they may also be associated with candidiasis and can also cause hypersensitivity reactions, potentially Stevens-Johnson's syndrome. Is that it? No. Why did I say Stevens-Johnson's? Where did I read? I know antibiotics can cause that, but why? No, it should just be photosensitivity. It can cause photosensitivity, GI discomfort, photosensitivity, arrhythmias, hypersensitivity, bronchospasm, interstitial nephritis, microscopic colitis, antifungal metronidazole. It can cause a disulfiram reaction, metallic taste, CNS, PNS toxicity, leukopenia, and colloidal bismuth. So start again. Okay, the triple therapy for a peptic ulcer disease involves the use of a proton pump inhibitor such as osomeprazole, a beta-lactam antibiotic such as amoxicillin, and a macrolide antibiotic such as clarithromycin. Proton pump inhibitors work by irreversibly binding to hydrogen potassium ATPase channels on gastric parietal cells, and as a result they decrease the hydrogen chloride release in the basal surface of the parietal cells. Their side effects includes gastric upset. They can also cause sleep disturbances. They're also associated with bronchospasm, interstitial nephritis, microscopic colitis, and can cause hepatic derangement. We also have our beta-lactam antibiotics, such as amoxicillin. These work by accumulating in the bacterial cell wall, and they bind to penicillin binding proteins, preventing the synthesis of the peptidoglycan cell wall. We get the accumulation of cell wall precursors, which is bactericidal, and side effects include typical side effects such as a rash, extreme nausea, vomiting, GI disturbance, and then rarer side effects can include anaphylactic reactions, interstitial nephritis. They can cause hematological toxicity, potentially encephalopathy. And we then have our macrolides. Our macrolides irreversibly bind to the 50S ribosomal subunit, inhibit bacterial polypeptide synthesis, and their side effects include gut motility issues, arrhythmias such as prolonged QT intervals, cholestatic hepatitis, rashes, eosinophilia. We also can use metronidazole if amoxicillin, patients are allergic to amoxicillin. The action of these classes of drugs, your 5-nitroimidazoles, is not fully understood, and it's associated with the production of free radicals that may directly damage DNA and impair DNA synthesis. And side effects can include a leukopenia, lymphopenia, and also can observe peripheral nervous system and CNS toxicity, and they can also cause a metallic taste and a disulfiram-like reaction, as they can... How do they do that? Okay, they can also inhibit acetaldehyde dehydrogenase. They also have effects on acetaldehyde dehydrogenase, causing a disulfiram-like effect with alcohol. That ain't right. What just happened with the time? It's 11. No. 15 minutes. Okay, your tetracyclines, we've already mentioned. Chelate calcium can cause enamel dysplasia, bone growth deformities, potentially photosensitivity, GI discomfort, candidiasis. Photosensitivity. So your beta-lactam, you can consider interstitial nephritis and cephalopathy, hematological toxicity, and photosensitivity. And colloidal bismuth is not bad. What is the mechanism of action of two of these drugs? Your aminosalicylates include sulfasalazine and mesalazine, and the mechanism of action is not clearly understood, but they're associated with the... Where is Key's case? Okay, so your aminosalicylates can cause alveolitis, meningitis, infertility, nausea, vomiting, orange discoloration. So your aminosalicylates can cause fibrosing alveolitis, meningitis, infertility, that's reversible, nausea, vomiting, and your orange discoloration of fluids. And the mechanism of action is unclear, but they have a toxic effect on... They're localized to the bowel wall. As they're poorly absorbed, they have toxic effects on lymphocytes and can impair the adaptive immune response, particularly the T-cell mediated response. Your corticosteroids are taken up via nuclear receptors, bind to transcription factors that can upregulate cytokine production, such as TNF-alpha, and as a result, we get alteration of gene transcription. And we should also know mechanism of action of steroids in much more detail. So, all right, we'll come back to that. The Steroids Act. How do corticosteroids work? Corticosteroids mechanism of action. Steroids mechanism of action. Lipocortin. Okay, steroids increase synthesis of lipocortin, a phospholipase A2 inhibitor, decreasing the production of inflammatory mediators, and they suppress the ectopic neural. That makes more sense. So, cellular mechanism of steroids. Steroids can bind, so they have genomic and non-genomic effects. So they can inhibit lipocortin, which is a phospholipase inhibitor, as a result reducing the inflammatory response. Glucocorticoids, thymocyte, T-cell apoptosis. They can cause collagenase, induction of gluconeogenic enzymes, bone metabolism. They also act through increasing transcription of, decreasing the translation of inflammatory genes, and they can also cause T-cell apoptosis. They can cause immune cell apoptosis, such as monocyte T cells, that can cause immunosuppression. They can also cause gluconeogenesis, impair lung development, and what's going on here? I need to know this much better. Bind to glucocorticoid receptors uptaken, and they can increase transcription translation of anti-inflammatory genes such as annexin A1 that can send anti-inflammatory signals. Steroids inhibit the production, produce lipocortin, can increase lipocortin, which can decrease phospholipase A2. mast cells, epithelial cells, arachidonic acid, eicosanoids, cell wall synthesis. It's the production of corticosteroids such as annexin A1, which can inhibit your phospholipase A2, and that prevents the formation of arachidonic acid in your cell precursors, and they of lipocortin, which is annexin 1, which is a phospholipase A2 inhibitor. Okay, so to sum this up, steroids, they bind to glucocorticoid receptors, and they are bind to glucocorticoid receptors. They're taken up into the nucleus and bind to nuclear receptors and increase the transcription of anti-inflammatory genes and produce lipocortin, which is also known as annexin A1, which is a phospholipase inhibitor. Phospholipase A2 inhibitor. This prevents conversion of the cell membrane into prevents the conversion of the cell membrane into arachidonic acid. And decreasing inflammatory cytokines. What are the side effects? Well, glucocorticoids can have immunosuppressive effects. They can induce T-cell and monocyte apoptosis. They may also cause osteoporosis, increase hyperglycemia, and that can increase the risk of thrush. What are some other effects not used in maintenance? Mechanism, side effects, osteoporosis, corticosteroids, passage that's on steroid receptor complex, and they got a known stimulate the production of glycoprotein called lipocortin, inhibits phospholipase A2, which prevents production of prostanoids and leukotrienes. Corticosteroids inhibit the corticoid known to stimulate after passage through cell membrane, they react with the receptor proteins in the cytoplasm to cause a steroid receptor complex, move into the nucleus, they bind to DNA, and they alter the transcription of mRNA. Known to stimulate the production of lipocortin, and they are also known to inhibit mRNA responsible for lipocortin, the glycoprotein, into arachidonic acid, which decreasing in prostanoid and leukotriene synthesis, which are inflammatory cytokines. Is prostaglandin a cytokine? Are important effector molecules. Cytokines release prostaglandins and other histamine leukocyte cytokine secretion, interleukin, gym necrosis. prostaglandins. No, it's inflammatory modulators. Modulate immune responses. So it is prostaglandin, a cytokine. Increases prostanoid and leukotriene synthesis, lipocortine, and it also decreases transcription of cytokine genes. And side effects, specific action, background, essential. What are their side effects? Increase anti-inflammatory, anti-mitogenic effects. Side effects of glucocorticoids. They can cause weight gain, water retention, mood swings, blurred vision, trouble sleeping, muscle weakness. It's all very vague. Osteoporosis, hyperglycemia, potentially a weight gain as well. It can cause so many damn effects. Let's go to dermatological. The open device up. Oh my god, I've never searched Micromedics before. Australian Medicines Handbook. What if I search moxicillin? Holy smokes, I've never seen this before. Let's call it, let's search for glucocorticoid. Prednisone. Holy the mode of action. They regulate gene expression, which results in glucocorticoid effects, proteolysis, lipolysis, gluconeogenesis, suppression of the inflammatory and immune response. They can have mineralocorticoid effects. Mineralocorticoid effects by there's hypertension, sodium and water retention. Receptors, e.g. like aldosterone. They can cause hypernatremia, water retention, low potassium. Wow, that's so good. Lipolysis, It causes hypoglycemia. Regulates gluconeogenesis, glycogenolysis, proteolysis, and gluconeogenesis, proteolysis, and lipolysis. And you can use mineralocorticoid effects, indications used in doses, increased risk of peptic ulcers, precautions. It can worsen hypertension, glaucoma, it can increase intraocular myasthenia gravis, it can precipitate a crisis, and then contraindications of glucocorticoids. The side effects of glucocorticoids can be broken down into the decreased inflammatory response. It can also, contraindications, diabetes. It causes hypoglycemia, latent TB, immunosuppression, can reactivate infection. Going back to its side effects, it can also cause hypertension, so it's probably not your best line of medication for hypertension, and congestive cardiac failure can worsen water retention. Decision, number of factors, injection route, surgery, adverse effects, flushing, hirsutism, common infection, edema, hypertension, hypokalemia, diabetes, dyslipidemia. It can cause abnormal osteoporosis, fractures, dyspepsia, skin atrophy, bruising, and acne. Skin atrophy, bruising, and acne. You think in terms of your Cushing effects, right? So you can cause hypoglycemia, weight gain. You can cause bruising, skin atrophy, acne, hirsutism, growth retardation, muscle weakness, fat distribution, weight gain. Sheesh. Peptic ulceration can cause gastric motility issues. So peptic ulcer disease. Glucocorticoids. Glucocorticoids. Let's go with aminosalicylates. So we said the main aminosalicylate that I cared about was mesalazine. What the hell did it do? What's the mode of action of these five? Exact mechanism unknown, anti-inflammatory, and precautions, adverse effects. Common nausea, vomiting, rash, headache, diarrhea. Nausea, vomiting, infertility, uncommon. Very rare, cause interstitial nephritis, blood dyscrasias, hepatitis, infertility or interstitial nephritis. Infertility, potentially even an interstitial nephritis, sort of colitis, Crohn's disease. So that's how they do something. Cool. Right, next. What are the guidelines for the management? Should literally copy paste this. So, azathioprine is a, what is the exact? It's a purine anti-metabolite, so it's metabolized via mercaptopurine to thioguanine nucleotides. Azathioprine is metabolized via mercaptopurine. Phenotype. Suppression. Bone marrow impairment. Infection. Allopurinol. Xanthine oxidase inhibitors. Pemphigus. Used for DMARD. You can cause dose-related myelosuppression. That makes sense. You have severe myelosuppression. Azathioprine versus 5-mercaptopurine. How does that work? Images. 6-mercaptopurine. Okay, azathioprine is broken down into 6-mercaptopurine, and that is then further broken down into thioguanine nucleotides that interfere with purine synthesis. So it's a purine anti-metabolite. Azathioprine will then break down to 6-mercaptopurine, and then finally into thioguanine nucleotides, interrupting DNA synthesis. So that's the mechanism of action of corticoids, antimetabolites. 6-mercaptopurine, metabolized by TPMT, second of severe myelosuppression, TPMT prior to prescribing. So I think I need to write a bit more on this. So aminosalicylates, mechanism unknown, it accumulates in the bowel and has toxic effects on our lymphocytes. Glucocorticoids and your purine anti-metabolites. It's then broken down into purine synthesis and then thioguanine nucleotides, which interrupt with purine and DNA synthesis. But if you levels of TPMT, you get severe DNA impairment. That makes sense. Purine anti-metabolite. So it's broken down. So azathioprine. Azathioprine is broken down into 6-mercaptopurine and eventually forms thioguanine nucleotides that interrupt purine synthesis. azathioprine and thiopurine methyltransferase. Let's break this down. Broken down via thiopurine methyltransferase. Thiopurine methyltransferase. Side effects. Side effects of thiopurine methyltransferase. Well, the side effects is that it's interrupting with DNA synthesis. When you interrupt DNA synthesis, you may get myelosuppression. What else can you get? Genotype, it is xanthine. Severe myelosuppression, STPM-TMT does not identify all patients. Regular blood count monitoring is still required. Determine TPMT activity. Can be severe prior patients with a TPMT mutation. Hence determine phenotype prior. What else can we do? Interaction with allopurinol, reduce azathioprine metabolism. With allopurinol, increasing the risk of severe pain. Okay, they're broken down. Xanthine oxidase inhibitors. Immunosuppression, there can be infection. Renal hepatic impairment. Infection. Alopecia, nausea, vomiting, mouth ulceration. Yeah. Can cause alopecia. Chemotherapy side effects. It can cause nausea, vomiting, alopecia, mouth ulceration, esophagitis. That makes sense. Okay, what are the guidelines? So typically for ulcerative colitis, our goal is for induction, maintenance, and preventing remission. Your first-line therapies for ulcerative colitis include the use of corticosteroids, and we can potentially consider adding corticosteroids alongside a 5-aminosalicylate. So the use of corticosteroids alongside an aminosalicylate, and if severe, we can consider adding a purine antimetabolite such as azathioprine or 6-mercaptopurine, and furthermore we can consider adding infliximab, vedolizumab. Azathioprine is first line in the maintenance for Crohn's. UC, mesalazine is preferred. We add severe disease, we add on mesalazine. For UC, we don't use mesalazine in Crohn's. Mesalazine not preferred in Crohn's. UC, oncology. Turn into toggle list. So let's go back here. Dermatological. Yeah, I can go to Crohn's vs UC. up and get the up-to-date guidelines. Crohn's disease. We would prefer for induction therapy. Is the most effective drug for treating active Crohn's disease. In fact, any parts, it's focal, transmural, endoscopic, histological, radiological, and we're trying to induce remission in active disease, maintain corticosteroid-free remission, and prevent relapse, and achieve mucosal healing where possible. The goal is to induce remission and then maintenance without corticosteroids, and then minimize complications. In contrast to ulcerative colitis, vitamin salicylates and rectal therapy have a limited role in Crohn's disease. Okay, principles. Goals of UC and Crohn's is to induce remission, maintenance, and prevent complications, restore bowel mucosae, and 5-aminosalicylates have limited utility in Crohn's disease. We prefer using okay, so for induction therapy we solely use your severe. We can use steroids, and then we can consider azathioprine, mercaptopurine, methotrexate. Methotrexate inhibits nucleotide synthesis, which is fine. What specific enzymes does it inhibit? The dihydrofolate reductase inhibitor, which prevents the production of purine synthesis. It's a dihydrofolate reductase inhibitor. Methotrexate dihydrofolate reductase inhibitor. So thiamine decreases homocysteine. Methotrexate DMARDs. Topic. Summary. Crohn's. Induction. Steroids. Corticoids. Corticoids minus azathioprine antitabulates, methotrexate for your biologics, refractory, and then maintenance. Maintenance is with azathioprine or 6-mercaptopurine. Azathioprine or 6-mercaptopurine, and we can do plus minus methotrexate, and then biologics. Such as infliximab, adalimumab, and then perianal fistulas, metronidazole, which makes sense. What about UC? What about ulcerative colitis? Let's go back up to ulcerative colitis. There we go. Induction therapy. Give mesalazine. And we can add corticosteroids. And mesalazine. We can add corticosteroids, and then it's the same thing, and then we can start adding methotrexate or biologics. And it's severe. Introduction, initial, maintenance therapy. Same thing. Okay. So then for Crohn's, we use that, and then maintenance. So initially the goal is glucocorticoids, and if it doesn't work, then we add everything else. Your methotrexate, your azathioprine, 6-mercaptopurine, and we can consider methotrexate and biologics. And the maintenance therapy is typically with azathioprine or 6-mercaptopurine. And similarly for ulcerative colitis, the induction is typically with aminosalicylate. And then you can do plus, minus, azathioprine. And for maintenance, we can go. And then for maintenance, we can go your antimetabolites. Same as Crohn's. It's just if it's refractory. The induction therapy is different. The induction therapy is aminosalicylates. That's it. Key difference is aminosalicylates. That's what I have to remember. Let me color it to a red background so I don't forget. Glucocorticoids, antimetabolites, and 6-mercaptopurine. Done. Alright, post-operative analgesia. Let's do this. Okay, so let me take a 5-minute break. We'll do our second hour. Alright, 5-minute break. Let's go. Okay, goal, post-operative analgesia. Let's start a timer for this one. Actually, let's quickly go to 80-year-old man comes in for a hemicolectomy. He has biventricular heart failure. After operation, he complains about abdominal pain. Okay, I'm concerned about infection, potentially a surgical wound infection or deeper, maybe post-surgical abscess. Concerned about ischemia following surgery, given that he's got cardiac failure, decreased cardiac output. What is wrong with his medication chart? He's required PRN medications. Your date of birth, male. He's taking, I can't even see that. Let me zoom it up fully. Alright, he's 4th of the 5th, he's taking Paracetamol, hourly frequency, max dose in 24 hours. Can't read that, it's for pain. Signature, print name, you've got the full name. Danzatron. Taking morphine on Danzatron. The dose appears okay. The dose of paracetamol is not given. And on Danzatron, but what is wrong with it? Risk of paralytic ileus. So he's had recent abdominal surgery. So you would not consider root oral does not make sense. And prescribed as regular medication, not PRN, especially what post-operative. Where does it say PRN? PRN or post-operative pain arrays moderate to high. IV infusion 1 gram QID. Max dose 4 grams in 24 hours. Oh, he's just on tablets. It's ridiculous. Morphine should be given IV is subcut. IM has variable absorption rates. Pain is associated with injection, injury to the muscle from repeated. So as variable absorption and muscle injury, patients who require multiple doses of morphine should be administered by a PCA IV infusion. PCA IV infusion or an indwelling subcut needle. PCA IV infusion or indwelling subcut needle rather than PRN. PCA is most preferred as it can self-administer and documents parameters. And there's lockout times. Subcut on wards can be about 5 milligrams, 3 hourly. IV is only available in the high dependency unit setting, and you could consider adding Movicol or lactulose to reduce constipation. Ondansetron should be given IV, not IM. So routes of administration are incorrect. So the patient just finished abdominal surgery. There's a risk of paralytic ileus. So we should not be giving oral administration. IM, we are concerned, should be IV or oral, but this patient cannot take it. And morphine should not be IM. Okay. What would be the most appropriate analgesia and why? Well, I gotta know what the pain ladder is again. Pain ladder. So a non-opioid or adjuvant therapy, we could consider a weak opioid or multimodal. And then we could consider a strong opioid. And then non-opioid or adjuvant. Use a non-opioid or adjuvant. Opioid plus minus non-opioid and adjuvant. And then opioid plus non-opioid plus an adjuvant. You can use paracetamol, Nsaids. Consider low dose like tramadol. Yeah, so use paracetamol or another NSAID, a weak opioid and an NSAID, and then a strong opioid or an NSAID. So pain letter. Okay. Opioids. Multimodal analgesia that is opioid sparing in nature. Use paracetamol 1 gram QID 4 times daily. So that's 8 tablets. Give IV for patients vomiting. Use the need for opioids increases the quality of analgesia. NSAIDs can be used, work synergistically with paracetamol to reduce opioid requirements. Avoid in this case as there is a bleeding risk with NSAIDs. Watch out for co-administration of an NSAID with a loop diuretic and ACE inhibitor. Opioids used in intermediate post-op period. IV subcut and use PCA lockout. To be a 5-minute lockout. You need to monitor their sedation score. It's more sensitive than respiratory rate. And you can co-administer with. Well, what is the sedation score? That's what I want to know. Sedation score. Sedation score. Are they drowsy? They're lightly sedated. Sedation score. ICU depths of sedation. What is a World Health Organization pain management ladder? It's an analgesic ladder created by the World Health Organization as a guideline for the use of drugs in the management of pain. We initially begin with a non-opioid and an adjuvant. This could be an anticonvulsant or an antidepressant or a membrane stabilizer. What is a membrane stabilizer? Anyway, if you have pain, we can begin with a non-opioid pain relief with use of a adjuvant therapy, and then we could consider using a weak opioid plus a non-opioid and an adjuvant, and then finally a strong opioid. It's non-opioid and adjuvant. Antidepressants, anticonvulsants. I would use paracetamol over NSAIDs in this case. They're equally effective, but it's safer for the elderly population due to the risk of bleeds. Why do we have bleeding the inhibition of COX-1? So we have one heart and we have 2 kidneys. That's how I'm going to remember it. Okay, so by inhibiting COX-1, we inhibit the production of thromboxane A2, which is important for platelet aggregation. By inhibiting COX-2, we can dilate the afferent arteriole, which can reduce the glomerular filtration rate and reduce GFR. And you have decreased production of thromboxane A2, which is critical for platelet aggregation, so impairs the platelet plug formation. So the patient is on biventricular cardiac failure. They likely also have concurrent take of the they're hypertensive. They could be taking an ACE inhibitor and diuretics. And adding an NSAID on can increase the risk of acute kidney injury, and that's because a loop diuretic causes dehydration, and there is heavy renal autoregulation. The NSAID dilates the afferent arteriole, and the ACE inhibitor causes vasodilation of the efferent arteriole. So rely largely on the... Okay, can you explain the triple whammy? The triple whammy is a syndrome, not a syndrome. Triple whammy is a complication of concurrently taking a ACE inhibitor, a loop diuretic, and a NSAID. And taking an NSAID results in dilation of the afferent arteriole due to prostaglandins, and concurrently taking a ACE inhibitor results in dilation of the efferent arteriole. Dilation of the efferent arteriole results in increased renal reliance upon the afferent arterial vasoconstriction for autoregulation of glomerular filtration rate. Given that we have also dilated the afferent arteriole, this can decrease glomerular filtration rate, and when concurrently taking a loop diuretic, this further reduces blood flow to the kidney, and these three factors can concurrently cause an acute kidney injury. So the loop diuretic is decreasing blood perfusion to the Urease diuresis, decreases perfusion to the glomerular capillary network. The use of a ACE inhibitor results in efferent vasodilation, which results in increased renal reliance upon the afferent arteriole for autoregulation of glomerular filtration rate, and concurrently taking a NSAID can result in vasodilation of the afferent arteriole as well. What is the mechanism of action of paracetamol? It's unknown. It has analgesic and antipyretic effects, but not anti-inflammatory effects. It only affects COX-2 in the brain and not in the peripheral tissue. It has analgesic and antipyretic effects, but it's not anti-inflammatory, so non-steroidal anti-inflammatory. Its mechanism is unknown. It's analgesic and antipyretic, but it's not anti-inflammatory. Affects COX-2, not the peripheral tissues. Analgesia, inhibition of central prostaglandin synthesis, and modulation of serotonergic pathways. I have no clue what that means. Causes hepatotoxicity, N-acetyl-P-benzoquinone. N-acetyl-P-benzoquinone, imine, produces toxic metabolites. N-acetyl-P-benzoquinine, imine? N-acetyl-P-benzoquinone, imine. Anyway, it's analgesic and antipyretic effects, but it's not anti-inflammatory. It causes analgesia by inhibiting prostaglandin synthesis and serotonergic pathways in the brain. It's antipyretic because it decreases production of prostaglandins in the hypothalamus. It's antipyretic because it decreases production. It's a COX-2 inhibitor in the brain, but not peripheral tissues. So paracetamol is an antipyretic and an analgesic, and it has anti-inflammatory effects in the brain but not in the peripheral tissues. It inhibits central prostaglandin synthesis and serotonergic pathways. Reduced production of prostaglandins results in peripheral vasodilation. Prostaglandins decrease, vasodilation occurs. Used as an adjuvant to reduce the required opioid dose, limiting adverse effects. Can cause hepatotoxicity, Stevens-Johnson syndrome, skin rashes, nausea and a headache. Can cause hepatotoxicity and overdose, skin rashes, nausea, headache. It's formed in very small quantities and quickly removed by glutathione, but it's very reactive and acts like an oxidizer. You treat this with N-acetylcysteine which is a glutathione precursor. So it's immediately removed by glutathione, but N-acetylcysteine is the antidote because it's a glutathione precursor. We can use 1 gram QID, maximum of 4 grams daily, which is 8 tablets. Okay, so Nsaids, they're non-selective cyclooxygenase inhibitors. They irreversibly acetylize cyclooxygenase, and they can reduce the production of prostaglandins, thromboxanes, and prostacyclins. By inhibiting COX-2, they have anti-inflammatory, analgesic, and antipyretic effects. Inhibiting COX-1, they can impair they can decrease secretion of bicarbonate, increase platelet aggregation, and dilation of the afferent arteriole, and decrease GFR. They maintain mucosal blood flow and secretion of bicarb. So it decreases bicarbonate secretion. How many stomachs do you have? Increase breakdown. Prostaglandins, COX-2 is induced in inflammation. Inhibition of COX-2 is inducible anti-inflammatory, antipyretic. It increases your thrombus risk. And by inhibiting cyclooxygenase 1, the prostaglandins are normally expressed and they maintain mucosal blood flow. Platelet aggregation is important for the production of thromboxanes and the dilation of the afferent arteriole. So by reducing increased platelet aggregation, these inhibit platelet aggregation that increases thrombosis risk. So COX-2 is your cell-coxib, your alpha-coxib. COX-1 is your normal. right? Heart is more important, so that's why it's COX-2. Your heart problems, GI dyspepsia, GI bleeding, gastritis, acute renal failure, electrolyte and fluid abnormalities, acute renal failure due to afferent vasoconstriction, acute renal failure due to afferent vasoconstriction, and cardiovascular stroke risk, usually with COX-2, as they reduce prostacyclin, which is an old form of endothelium. COX-1, more thromboxane, increased bleeding risk, bronchospasm by cyclooxygenase, pelvic ulcer disease, anaphylaxis, Stevens-Johnson syndrome. So renal, GI dyspepsia, renal, cardiovascular, and they can impair platelet aggregation, anaphylaxis, Stevens-Johnson syndrome, and hepatotoxicity. Okay. Non-steroidal anti-inflammatory drugs work by impairing cyclooxygenase. They can be classed as cyclooxygenase class 1 or class 2. By characteristically inhibiting the cyclooxygenase class 2 isoenzyme, we observe decreased anti-inflammatory effects. However, we also get concurrent inhibition of cyclooxygenase 1 isoenzymes. As a result, we get effects on platelets, GIT mucosa, and the kidney. By inhibiting cyclooxygenase 1 in platelets, that inhibits thromboxane 8-2 formation, which is critical for platelet aggregation. So this may result in an increased bleeding risk. We may also decrease the production of prostaglandin-mediated bicarbonate production, and as a result increase the risk of peptic ulcers and GI bleeding. And we also observe dilation of the afferent arteriole mediated by decreased prostaglandin synthesis. And this results in reduced GFR. The use of cyclooxygenase class 2, the use of COX-2 inhibitors results in the increased risk of thrombosis as we decrease the production of prostacyclin, which is expressed by normal endothelial tissue. Other side effects can include rash, Stevens-Johnson syndrome, anaphylactic reactions, and rarely hepatotoxicity. Inhibiting cyclooxygenase increase pathway down the leukotriene pathway, so you can get a bronchoconstriction as well. So analgesia, antipyresis. Can you explain how the two NSAIDs work? So paracetamol is an antipyretic and an analgesic, but not an anti-inflammatory agent. Its mechanism of action is through the central nervous system, and it inhibits cyclooxygenase 2. Okay. Paracetamol is an antipyretic and an analgesic agent, but is not anti-inflammatory. It inhibits cyclooxygenase 2 in the brain, and thus reduces the prostaglandin-mediated pain pathways in the cortex, which can involve serotonergic neurons. Side effects can include primarily hepatotoxicity, and this is due to the buildup of toxic metabolites that are normally broken down by glutathione in small quantities. The toxic metabolites can increase free radical damage to the liver and potentially cause an acute fulminant hepatitis. The antidote in a paracetamol overdose is N-acetylcysteine. Other side effects can include nausea, vomiting, headache, potentially photosensitivity. No, it's rashes. It's just so rashes, nausea, headache. Side effects relatively safe, but it can cause nausea, vomiting, rashes, headache, hepatotoxicity. Okay, so again, paracetamol is an antipyretic and an analgesic, but not an anti-inflammatory agent. It decreases the production of prostaglandin in the central nervous system by inhibiting cyclooxygenase 2 isoenzyme. It can result in the production of toxic metabolites that are normally broken down by glutathione. However, no, I need to explain why it's an antipyretic. It's an antipyretic by decreasing prostaglandin, so this causes vasodilation and heat dissipation. Okay, so paracetamol is a antipyretic and an analgesic, but not a anti-inflammatory agent. It works by decreasing your cyclooxygenase 2 isoenzyme in the central nervous system in the brain. Decreased levels of cyclooxygenase 2 isoenzyme activity results in decreased prostaglandins, and this can decrease serotonergic pain pathways in the cortex and also result in vasodilation through action on the hypothalamus. And by increased heat dissipation, we also get a decrease in temperature. Its side effects include hepatotoxicity, and this is secondary to the production of toxic metabolites that are normally scavenged by glutathione. The glutathione may the antidote for this is N-acetylcysteine, and this is a precursor to glutathione. Other side effects include nausea, vomiting, and a rash. And the other Nsaid is... The other class of medications are Nsaids, and these are non-selective, irreversible, it's aspirin. The other class of medications are Nsaids, so non-steroidal anti-inflammatory drugs. And these work through inhibition of cyclooxygenase 2, which is typically responsible for your production of prostaglandins, which are inflammatory mediators, and upregulate cytokine release in the acute inflammatory response. Their side effects can be associated with their inhibition of cyclooxygenase 1 isoenzyme activity. By inhibiting COX-1 in GI mucosa, this decreases prostaglandin-mediated bicarbonate synthesis. As a result, there will be increased risk of gastric mucosal ulcers and bleeding, and we may also get decrease in we may also get vasodilation of the afferent glomerular arteriole, and this may predispose to acute kidney injury, especially in the context of concurrent use of a loop diuretic and an ACE inhibitor alongside the NSAID. Other side effects include inhibition of prostaglandin inhibition in platelets, which decreases thromboxane A2 and can impair platelet aggregation. Other side effects can include rashes, Stevens-Johnson syndrome, and much rarer hepatotoxicity. What is Nsaids? Holy smokes, how much do they ask this? What is the mechanism of action of opioids? They bind to mu, delta, kappa opioid receptors, and they can hyperpolarize cells. Opioids, they you can open potassium cells, result in hyperpolarization of neurons, and they can increase calcium influx. Okay, a bit transition of ascending signals at the dorsal horn. They can increase descending inhibition of nociceptive signals. How is that a word? Paragigantocellularis, the reticularis, nucleus reticularis, paragigantocellularis. Oh, I feel like I made this up. How is a word that big? Nucleus reticularis, paragigantocellularis, periaqueductal gray area. No, not remembering that at all. Okay, let's focus on what we've got right now. So they inhibit GABA inhibition of dopaminergic activity in the ventral tegmentum. The ventral tegmentum. This can increase your pleasure response. So mechanism of action of opioids, they bind to mu, kappa, delta receptors, and they may act by reducing cyclic AMP, inhibiting adenylate cyclase, reducing cyclic AMP, and that may result in calcium influx into cells, hyperpolarizing them. They can also act on presynaptic neurons, prevent calcium influx, and they can also inhibit increase the activity of inhibitory pain signals from the periaqueductal gray area. Codeine is a prodrug that's broken down into morphine, converted by the cytochrome P450 family of isoenzymes into morphine, and it is attempts to lack the D2 isoenzyme, and they don't get analgesic effects. They're ultra rapid metabolizers, and there's a risk of morphine toxicity. Why would you choose one opioid over another? Are there any examples? Work according to the World Health Organization pain ladder. They're given by a variety of routes. Prefer IV and subcut. Could potentially do IM. Morphine or fentanyl is preferred for severe pain because of availability and cost. It's a drug of choice for post-operative analgesia as a rapid onset. Half-life, oxycodone, hydromorphone. Weak is codeine, tramadol, or tapentadol is preferred over tramadol. And strong is morphine, fentanyl, oxycodone, hydromorphone, dilaudid. Dilaudid is hydromorphone, right? Dilaudid is hydromorphone. It's very strong. So highly strong. So morphine, fentanyl is quite rapid acting and has a shorter half-life. Morphine can last longer. And then there's hydromorphone. And there's codeine, oxycodone, codone versus morphine. Oxycodone has a decreased affinity to the mu-opioid receptor. G-protein coupled receptors, and each heterodimers so moves it, but its affinity, also concentrations, need detectors measured by higher than that. It's part of this is about equally potent or more potent than morphine after systemic administrations. Bioavailability, different metabolites. Morphine is responsible, whereas that morphine 6-glucuronide, similar. Tramadol to pentadol, codeine. What factors? The amount of pain, chronicity. You can use longer acting opioids as opposed to tramadol. Extended release, opioid addiction, titrate to patient response, and poor compliance. That's like just fentanyl transdermal patches. So amount, chronicity of the pain. I'd be worried about opioid addiction. So methadone is a good choice. It's used in maintenance therapy. Compliance. Ease of vascular access, GIT, respiratory depression, judged by sedation score. 0 is awake, 3 is non-rousable, and you have to titrate to keep the sedation score less than 2. Okay, CNS depression, GIT, nausea, vomiting, constipation. Can also affect the eyes, cause meiosis, suppression of the cough reflex. Opioid receptor activity inhibits intestinal motility by depressing acetylcholine release from the myenteric plexus, and toxicity, chronic kidney disease. Don't want to use it with tricyclic antidepressants, both have depressive effects. Alcohol, benzodiazepines. So what are the side effects of opioid medications? Opioid medications can affect the respiratory and central nervous system, causing CNS and respiratory depression. They can also cause meiosis, constipation, nausea and vomiting. They can decrease. They can also cause nausea, vomiting, constipation, and they do this by decreasing acetylcholine release from the myenteric plexus. Eyes, suppression of the cough reflex. Eyes, cough, chronic kidney disease, CNS, respiratory depression, nausea, vomiting, constipation. Eyes, chronic kidney disease, cough reflex. You would not like to concurrently use it with other depressant medications and hyperalgesia. Don't understand how. There's morphine overdose. Use multimodal analgesia. It's regional anesthesia, and you could use a PCA monitor sedation. So we could use multimodal analgesia, PCA monitor the sedation score being less than 2, and we'd like to recognize the opioid overdose triad, decreased consciousness, pinpoint pupils, and respiratory depression. So the pupils are very important. There is a triad of opioid overdose, which is respiratory depression, CNS depression, and pinpoint pupils. So you can engage in basic life support, immediate IV naloxone. Naltrexone is used for alcohol withdrawal and has a rapid onset of action. Naloxone reverses sedation, respiratory depression. It's 1 hour. Most commonly used due to shorter half-life. We need to monitor. So that's in 4 hours. You need to consider N-acetylcysteine, activated charcoal, and 4 to 8 hours you can check the Panadol levels and consider N-acetylcysteine, check levels. So what I order: AST, ALT, INR, UCs. It's a serotonin receptor antagonist that acts both centrally on the chemoreceptor trigger zone of the medulla oblongata and peripherally on the vagal afferent neurons to prevent stimulation of the vomiting center, the area postrema. The chemoreceptor trigger zone, the medulla, and it prevents vagal activation. So it's serotonin antagonist. Nausea, vomiting, and prevents abdominal straining from surgical wound dehiscence. It's 4 milligram wafers. use metoclopramide, which is a dopamine antagonist, but it can stimulate bowel peristalsis. Metoclopramide. Who's an IV drug user? How would you alter your pain management? PCA with a background infusion, Suboxone, combination of buprenorphine and naloxone. Can't inject it. Must. For an opioid substitution program is methadone. On an opioid substitution program, consult with Ella. There are only providers for opioids. You could consult them regarding current medications. Monitor side effects. We're looking for sweating, tachycardia, pupillary dilation, hypertension, muscle cramps. Then you get a tachycardia, hypertension, pupillary dilation, cramps. Frequently request increasing doses, loss on medications, injectables, short-acting agents. Consult a pain specialist. So you can use PCA, consider Suboxone, methadone, buprenorphine. Pain is still managed. Would you change it to fentanyl or tramadol? Oxycodone, Zendone. We need to overcome narcotic. Neuropathic pain. Overcome the pain. Fentanyl or tramadol. I would consider fentanyl or oxycodone. Neuropathic pain and avoid tramadol. It potentiates withdrawal. We need to overcome opioid dependency. We need to overcome neuropathic pain. I would consider tramadol. Or less respiratory depression. To precipitate renal failure. And multimodal approach, possibly a nerve root block, an epidural, an anesthetic agent. Consider consulting anesthetics, anesthetic agent, epidural, or a nerve block. Fentanyl. Resuscitation. Insert. Basic life support. Naloxone. First up, how to manage an overdose, OVD, drug use. I have changed my approach. Higher doses. I need to consider pain-seeking behaviors and consider a pain specialist. Ondansetron is a serotonin receptor antagonist, which can act directly at the chemoreceptor trigger zone in the medulla, but also decrease vagal afferents to the area, the vomiting center of the brain. Okay, why would you not use metoclopramide? It can cause peristalsis. So I finished gastrointestines biomedicine. So gastrointestinal passes. Alright, so what haven't I passed? Neuro, room, genito, obstetrics, ophtha. Holy smokes. How many cases do I have? Let's see. Got diagnostics, upon 2. I've done graves. 3, 4, 5, 6. 6. Room. 7, 8, 9, 10, 11, 12.
Boy 50. Hey, yo, Travis.
17, 18. 19, 20, 21, 22, 23, 24. 24 cases, man. Holy smokes. So I need to go through what? If I do 6 a day, it'll take me 4 days to finish. If I can do 6 a day. I've got to finish it. I've got to finish it. There's no other option. Okay. Anyway, I gotta sleep now. I gotta wake up super early tomorrow morning.